Hi, and welcome to the Neurology Nook, where we dive deep into different topics of neurology, covering everything from Alzheimer's and stroke to the latest breakthroughs in research and technology. Hear inspiring patient stories, gain insight from top neurologists, and discover, most importantly, how to keep your own brain healthy. Hey, welcome back to the Neurology Nook. I'm Kelly, and this is my co-host, Dr. Modi. Today, we're diving into a critical condition, brain bleeds. Another word for this is brain hemorrhages. Now, you may be thinking, brain hemorrhages, that sounds terrifying, and you'd be right. It can be. But luckily, we have an expert here to break it all down for us. Please welcome Dr. Mohammed Kananeh. Dr. Kananeh is a leading neurocritical care specialist dedicated his career to treating patients with serious neurological conditions, from strokes and brain injuries to aneurysms and seizures. He underwent training at Thomas Jefferson University and Henry Ford Hospital. He's a renowned teacher and lecturer. But what makes Dr. Kananeh truly stand out is his commitment to patient advocacy. He's a tireless champion for improving access to neurologic care, ensuring everyone gets the treatment they need. Today, he's here to share his expertise on brain hemorrhages, a condition that affects a surprising number of people, almost 100,000 in the United States each year. These can occur from trauma, like falls or accidents, or they can happen spontaneously without trauma. We'll be focusing our discussion on the non-traumatic kind today. Thank you so much for meeting with us today. We are so excited to have you on our podcast.
Thank you very much. I really appreciate the invitation, and I'm very happy to talk about a condition that we see daily and sometimes multiple times a day in the ICU, where patients have to come to the ER for these spontaneous hemorrhages. There are a lot of risk factors that can lead to a spontaneous hemorrhage. There's population risk factors and medical risk factors. From a population standpoint, older age, males in general, and Asian descent usually have a higher risk rate. From a medical standpoint, we know uncontrolled hypertension is the leading cause of spontaneous hemorrhages. Other risk factors, of course, excessive alcohol use. That could be from withdrawal, because when someone goes into withdrawal, their blood pressure goes up. So that can lead to hemorrhages. Alcohol intoxication can lead to falls and brain bleeds. Other risk factors is, of course, the use of anticoagulants or blood thinners.
And more people are on it nowadays with aging population.
Exactly.
Mm-hmm.
The good thing is that we have new generations of blood thinners with a better risk factor profile, like our apixabans, our rivaroxabans, versus our older generation drugs, especially Coumadin.
Mm-hmm.
Warfarin.
And yes, thank you. These are more, the older generation drugs have a higher risk of brain bleeds because it's sometimes hard to control the levels. And lastly, of course, patients who take illicit drugs. I've seen a lot of spontaneous hemorrhages of patients who do mostly cocaine.
Does that come back to high blood pressure?
High blood pressure and also the vasoconstriction of the vessels.
Yeah.
When the vessels vasoconstrict and the blood pressure goes up too high, that can lead to rupture.
That makes sense.
Yeah.
Would you say smoking as well?
Smoking leads to the second part. Why do patients develop intracranial hemorrhage or spontaneous intracranial hemorrhage? As we mentioned earlier, like risk factor for intracranial hemorrhage is hypertension over time. It hardens the vessels.
Mm-hmm.
Elevated cholesterol causes a hardening of the vessels. When you have a hardened vessel and suddenly your blood pressure goes up, a normal vessel is very flexible. So when the blood pressure goes up, it can accommodate and expand.
But
I'm
there's
talking
no
about arteries, of
compliance.
course.
Yeah.
Exactly. So there's reduced compliance. So when the blood pressure goes up, the vessel cannot handle it and it can rupture.
So there are two main kinds of brain hemorrhages, the traumatic one and non-traumatic one. The traumatic one, as you mentioned, includes falls, motor vehicle accidents. The non-traumatic ones are the spontaneous hemorrhages. The most common risk factor is high blood pressure and using blood thinners. And then things like smoking and drug use like cocaine.
And I want to mention, as our population is getting older, and we're neurologists, we deal a lot with patients with dementia and Alzheimer's. That can lead to bleeds because of the deposit of amyloids. Amyloid is an abnormal protein associated with Alzheimer's and dementia. When it deposits in the brain, it's very brittle and can easily bleed. We see spontaneous hemorrhages in Alzheimer's or dementia patients. And when you look at the MRI, you see a lot of punctate or small bleeds in multiple parts of the brain.
Even in patients who have never had hemorrhage?
Yeah, so I've actually seen it with patients who have Alzheimer's. We can see small punctate hemorrhages or small
Wow.
hemorrhages in different parts in the brain as well. Yeah. And that actually puts them at a higher risk of the bleeding in the future. An issue if the patient needs to be on an anticoagulation or a blood thinner, because that puts them at a higher risk of bleeding even further.
That would be
That's the
important to
kind of
know,
thing.
With in
Mhm.
Alzheimer's disease patients, it's important to know if you do an MRI brain and see a burden of small hemorrhages in the brain, those patients are at a higher risk of developing a frank brain bleed. We need
Absolutely.
to avoid anticoagulants in that patient population.
I agree 100%. What's the incidence? It's about 24.5 or 24.6 per 100,000 person years, which translates to about 60 to 80,000 cases in the United States every year. So it's a fairly decent number. And that's why we need to know about it. The 30-day mortality can go up to 50%. So it's between 35 to 50%, and about 20% of patients can have full recovery in about 6 months. Not all bleeds are created equal. The location plays a big role.
Yeah, can you tell us
Cortical.
more about that? The location and the size. These are the
Mhm.
two main things we look for when we see a brain hemorrhage.
Absolutely. So usually when I look at brain bleeds, I look at three places. Cortical, meaning at the surface of the brain. Subcortical means the deep structures of the brain. Then usually at a deeper level is basically below the tentorium, which is the tissue that separates the upper part of the brain from the lower part. And we're talking about the cerebellum or the brainstem. It really depends on what the cause is. If someone comes in with a hypertensive emergency or someone's systolic blood pressure is in the 200s, the bleeding is usually subcortical in the deeper parts of the brain. The reason for that is those vessels in general are, in a normal person, they're very small and their compliance is not as good as the large vessels. So when you hit the brain with high blood pressure all of a sudden, those vessels can easily rupture and bleed. So that's why hypertensive emergencies, usually we see them in the subcortical or the deeper structures of the brain. If someone has cocaine induced or a blood thinner, usually it's more cortical. So going back to why is the location important? As we know, different parts of the brain controls different functions. The language center is in the left part of the brain, left temporal parietal area. If you have bleeding in that area, you can lose the ability to speak, lose the ability to move the right side. If you have bleeding in the frontal lobe, you can also lose some ability to speak, lose the ability to have executive functioning. Different parts of the brain, different function and different loss of function.
The most important functions are language, movements, vision.
Absolutely. And the deeper structures of the brain, it's usually about sensation and motor. A lot of our patients come in with ability to understand. They have intact language and executive function, but they are basically paralyzed on one part of the body, or they lose sensation on one part of the body.
Talking about the symptoms, for our listeners, can you go over the common symptoms they are looking for when someone experiences brain bleed? When should you call 911? When should you be concerned? What kind of symptoms they can have? When someone has an ischemic stroke, symptoms can be fast, means balance, vision, face, arm, speech. What about the brain hemorrhage?
ICHs or intracranial hemorrhage fall under the stroke umbrella. Very similar symptom, inability to move one part of the body, loss of speech. A lot of our patients develop seizures. Also, change in mental status. So people who are unresponsive, we see a lot of our patients unresponsive to the point that they actually need to be intubated in the field where they need to have a breathing tube and connected to a ventilator because of how severe the bleeding is and how large it is. The other thing we need to know regarding intracranial hemorrhages, again, location, if you have bleeding in the cerebellum, which controls balance, patients can have balance issues or vomiting, like they spontaneously start vomiting or have a severe headache. Things of that nature should be taken care of and should be something to look at. So patients who have a severe headache suddenly, start vomiting, become unresponsive, and, for example, loss of function on one side or seizures, need to pay attention and call 911 right away.
And then what happens after they call 911? What happens in the emergency room? How are these patients approached?
As with any patient in medically, we always do the ABCs, evaluate airway. What's the blood pressure? Are they able to be responsive? So that's the first function of EMS. If they feel that the patient is unresponsive, there's a scale we use called the Glasgow Coma Scale. If your GCS is low, you're probably going into a coma. At that point, the most important thing is to protect the airway, meaning you need to be on a breathing tube. Make sure that the airway is secure. Second, measure the blood pressure, see what it is. That will give us an idea of what's going on in the body. The other thing is to make sure that they don't have seizures. So you got to ask the family if there's any seizure activity, because if they did, they need to be put on a seizure medicine. The most important thing is to rush them to the hospital and get a head CT.
Yes, and the purpose of the head CT would be to look for the brain hemorrhage and location,
Exactly.
size, how sensitive the head CTs are. Like, does it always show hemorrhage?
It's very sensitive. I would say it's almost close to 100%. So it's like high
Okay.
90s. Even small hemorrhages, head CTs are very sensitive in detecting ICH. And that's actually a question that families were like, oh, why don't you do an MRI? A head CT, first of all, is quick. It takes a few minutes versus an MRI, which at least is half an hour. And of course, in a patient with an intracranial hemorrhage like this, they
You
can
need to move
deteriorate
quickly.
quickly.
Yeah.
Exactly. And
Absolutely.
with vessels that we cannot usually detect in the deep structures of the brain, we cannot really visualize them. However, I always advocate for a CT angiogram, which is a CT that also looks at the blood vessels in the brain. Sometimes your bleeds can be from an abnormal blood vessel in the brain. So it's good to do a CT angiogram of the brain to rule out any abnormal blood vessels, a blood vessel anomaly.
Aneurysms and AVMs.
Exactly.
In the emergency room, they had a CT scan of the head. If they see a bleed, they have a CT angiogram to look at the blood vessels. Now, what happens next?
Excellent. Like I said, we have to look at the blood pressure. Once the bleeding is confirmed, and if the blood pressure is high, we need to lower the blood pressure. If you look at the literature, goals has always been normal tension, meaning below 140. But if you dig deep in the literature, most patients who responded were actually below 160. It's always a discussion between us as neurointensivists and the neurosurgeon. Sometimes we go for a goal of below 140, sometimes below 160. The idea is to lower the blood pressure, because if you don't, you're going to expand the intracranial hemorrhage even further, and that's detrimental to patients.
Makes
The other
sense.
thing is to determine if the patient is surgical or not. Not all bleeds are surgical.
Tell us
So it
about
doesn't
that.
mean
What bleeds are surgical?
Who needs surgery? How many proportion of patients need surgery?
so basically when it comes to surgery, it depends on the location. You cannot really reach it invasively, meaning you don't remove it. However, there has been new advances with minimally invasive approaches, like a small burr hole, which is an opening in the skull the size of a quarter. They put in a device where it's almost like a suction to break down the clot while retrieving the blood out. It's a minimally invasive procedure. It has been shown to reduce the size of bleeding. However, it's controversial if it's really effective or not, meaning it's not sure if it actually helps with functioning.
And would
So
that be
this,
for subdural and epidural hematomas or any?
this is for the spontaneous hemorrhages that are deep.
Subdural would be traumatic.
I see what you mean.
When I look at an intracranial hemorrhage to determine if it needs evacuation or not, the location is important, and also the amount of pressure it produces on the brain. The brain is inside the skull, a rigid structure that doesn't expand. If there's bleeding, increases pressure in the brain, and that can cause shifts in the brain, and that can cause what we call herniation, where part of the brain moves from one side to the other.
Because of the swelling, the part of the brain swells because of the pressure inside from the hematoma, the blood. And so the brain shifts in different directions, and that can be quite detrimental.
that can be detrimental and actually life-ending. Unfortunately, we've had cases where patients come in with a large bleed and the shift has happened because of all the swelling, and unfortunately, it's too detrimental. Even if you evacuate, the damage has already done and there's really nothing to reverse. So that's important for me. I have to see how much shift and swelling there is. I want to see if there's evidence of herniation. The most important thing in any neurologic disease is what the exam looks like. We've seen patients with fairly large hematomas or hemorrhages in the brain with very minimal changes on the exam. So there's always going to be a discussion with the neurosurgery team. If we try to evacuate this blood, there could be more injury to the patient versus medical management. If someone comes in with, again, a large hematoma, evidence of a shift in the brain and changes in the exam, that's always going to prompt me to call the neurosurgeons for an evacuation. So that's something to keep in mind. But not all hemorrhages are surgical.
Actually, most
Absolutely.
hemorrhages are probably not surgical brain hemorrhages.
What does conservative management look like for this particular
Very good.
situation?
Excellent. First of all, blood pressure management. Is the patient on any blood thinners? And if they are, we need to reverse that agent because it causes blood thinning. And if the blood is thin, most likely the hematoma will expand, the hemorrhage will expand. So we need to reverse the effects. Depends on the agent. There are different reversal agents. That's a separate topic that probably needs an hour by
Yeah,
itself.
exactly.
So
blood
just
pressure,
about the
reducing
agent.
anticoagulation, and then you said something about sodium. Can you tell us more about that?
Absolutely. So when someone has increased pressure in the brain, and patients with hemorrhages usually have increased swelling in the brain, we give patients concentrated salt solutions in the IV to help bring the sodium up. What does that do? When the sodium in the serum or in the blood is high and the sodium in the brain is low, there is more fluid in the brain than in the serum. So the water, or AKA swelling, moves from the brain into the serum. And that technically will reduce the swelling in the brain.
Sure.
Of course, it's not always successful. And if it's not successful and the hemorrhage or swelling continues to increase in size and there's more shift in the brain, we have to talk again with the surgery team about the surgical option.
So if there is evidence of high intracranial pressure or brain swelling, you raise the sodium levels in the blood that allows the brain to shrink.
Pulling that swelling into the vasculature instead of
Yeah, pulling fluid into the vasculature, avoiding surgery, hopefully.
Exactly. And that's where my expertise comes in, which agents to use. How often do we need to check the sodium? When to call the surgeon to say, we did everything we can. I think you probably need to take this patient to surgery.
Neurointensivists probably spend 1/4 of their time discussing sodium.
Oh, I'm sure.
Probably more than nephrologists.
I was just going to say, you think more than nephrology? Nephrology and neurointensivists, we're all just like bags of electrolytes passing through membranes.
Yeah.
That's just evidence of that,
There
right?
are sodium protocols. Like the first question we ask, what's the sodium? And then we put the patients on sodium protocols. Okay, what's the goal sodium?
You've got your eye on that salt all the time.
We are very salty people.
Oh,
So
excellent.
now the other thing we need to look at, going back again to the location,
Sure.
because if you have bleeding in the deeper structures in the brain, and Dr. Modi, I'm sure he talked about this previously, we really don't have seizures in the lower structures in the brain. Deeper structures like the cerebellum and brainstem, seizures come is concentrated in the cortex. White matter doesn't seize. That's why bleeding in the deeper structures, I don't put them on a seizure medicine prophylactically. So even if a patient comes in with a cortical bleed, no evidence of seizures, I would put them on a seizure medicine to protect them from having a seizure, which is detrimental to the brain. If it's a deeper structure, I don't usually put them on a seizure medicine.
That makes sense.
We used to use more anti-epileptics before. Usually neurosurgeons are in favor of anti-epileptics, and then neurointensivist comes in and stops it.
Yeah. A lot of back
Again,
and forth.
That
They're like,
happens.
I just don't want them to have a seizure during my surgery.
yeah, exactly. Half of our neurointensives, half of our discussions are about sodium, and the other half is with neurosurgeons.
Oh my goodness, that makes
So now we're talking about preventing bleed from getting bigger, control the blood pressure, reverse the effect of blood thinners if patients are taking blood thinners, and
Mhm.
reduce the intracranial pressure using either raising the sodium levels or using the surgery, decompressing the brain, whatever it takes. Now, what does rest of the hospital course look like?
After they come to me in the ICU, I do serial scans, meaning I repeat CAT scan in a day or two. The reason for that is to make sure that the bleeding is not expanding. The other important thing is to use scales, something called the ICH score or the intracranial hemorrhage score. And there's another scale called the FUNC, the functional outcome of these patients. The intracranial hemorrhage score is a tool. It's not gospel, meaning I don't use it as that's it. The mortality is this and that's it. There's no hope. However, it's a tool to help us talk to families about prognosis. And it depends on what the GCS score is, what level of coma the patient was in when the initial symptoms started, what's the age, what's the location, what's the size of the hemorrhage, and the presence of intraventricular hemorrhage. Ventricles. Ventricles are the spaces in the brain, and it circulates something called CSF or cerebral spinal fluid. And the cerebral spinal fluid basically coats the brain, provides nutrients and all that. Sometimes when the bleeding is too large or very close to the ventricular system, it can seep into the ventricles. That's important because it can lead to worse mortality and morbidity when patients have intraventricular hemorrhage. The number that I get, a prediction of the mortality. The higher the number, the higher the mortality. So that's something I used to tell families, this is what we're dealing with. This is where the location of the hemorrhage, herniation present, not present. What's the functional status? They're on a ventilator or not, and this is the ICH score. So that's one thing to use. The other thing is the FUNC, even though I don't really use it that much, but it's a good tool about what Dr. Modi alluded to, which is basically what's the functional status going to be. And it's very similar to the ICH score, but it adds in what is the premorbid condition before having the spontaneous hemorrhage.
Sure.
A lot of our patients, if they're stable and don't die in the ICU, will need extensive rehab. And usually it depends on the location, depends on the premorbid condition, what's their functional status before. It's a little bit hard to tell the amount of people who respond, but you can use the FUNC. And from the literature, as I mentioned earlier, about 20% can go to being normal after 6 months.
Wow, that is a low number.
It is a tough condition.
Absolutely. I just feel like young brains bounce back better. I'm sure that's calculated as part of the score.
Absolutely. And as something I always say, don't bet against the young. If someone is young, don't bet against them. The thing that I want people to understand, you will have deficits. Similar to a stroke. The brain is injured and that tissue is gone. So you will have deficits. You will have a form of handicap. Hopefully with extensive rehab and speech therapy, your handicap will be low. Even young patients with a bleed can regain function, but rarely someone goes back to the same level of functioning as before. So it's very important to keep that in mind.
Absolutely.
Do you have any interesting case that you would like to share with our listeners?
Interesting case, something that I was going to talk about, like special cases. I had a woman who came in with headaches and seizures. We scanned her brain and she had a bleeding, cortical bleeding, very close to the surface of the brain. We scanned her arteries, but we also added another study where we looked at the veins. The veins actually had a clot in it.
Oh, wow.
Yeah. Veins take blood away from the brain and puts it into the rest of the circulation. So when that clot was there, the blood couldn't go through that vein. It pooled and went into the cortex, into the brain. When we looked into the history, she was taking oral contraceptives, and some of the contraceptives have a higher estrogen, and that can lead to venous clots. The treatment for that was actually different
Yes,
than other hemorrhages. We needed to put her on a blood thinner
in a brain
to break
hemorrhage.
down that clot. Yeah, to
This
break down
this
that
sounds
clot.
very counterintuitive, but
Yeah.
we use blood thinners for brain hemorrhage caused by
Exactly.
Caused by
uh,
a clot. Yeah.
venous thrombosis.
Venous clots. These are different than other types of bleeds. This is a special case, but it's always fascinating when I see this. The other thing we do with patients with hemorrhages, especially if it's localized or they have multiple bleeds, is one MRI of the brain with contrast. The reason for that is we want to make sure they don't have brain metastasis, meaning they might have a history of cancer, and that cancer, special types of cancer, when they go to the brain, they tend to bleed. Most famously is melanomas, for example. So we had patients who had, we had one or two patients who had multiple small areas of bleeding. And when we did the MRI, the melanoma went to the brain and bled. So these are also special cases
Yeah.
as well.
I really like
Spontaneous
how you
bleeding.
called attention to the thing about birth control pills can cause a higher risk of stroke and venous thrombosis, because now a lot of birth control pills are available over the counter. So that eliminates the ability for the doctor and patient to have that patient education. It's something you can just pull off the shelf, and it has more risk than what people realize. So I'm glad to have called that attention for our listeners. Have great conversations with your physician before accepting the risk. It's just not always as easy as just taking something off a shelf. There are risks to every medication that we take.
Especially if they take oral contraceptives and they smoke, risk is actually there.
Absolutely.
Yeah.
Anything you want to share with our listeners about what they can do to prevent brain hemorrhage?
I would say stop smoking, of course. Make sure your blood pressure is under control. I see a lot of families that say, oh, my loved one is healthy. Then you found out they didn't see a doctor in 20, 30 years, and they've been having high blood pressure for a long time. Follow up with your primary care doctor once a year. Make sure that you control risk factors like blood pressure and no smoking. Of course, no excessive alcohol intake. Talk with your provider about the risks and benefits about being on the type of blood thinner you need to be on, if you need to be on it. See what different products are there and their risk profile, and make sure you follow up with your doctor.
Good. Yeah. Thank you.
Wonderful.
Yeah.
Yes. Thank you so much for your insight. I feel like I was at an educational conference here. I love it.
Thank you very much for having me. It was a pleasure.
Absolutely. Thank you again for being on the show, and thanks for listening to the Neurology Look. We'll see you next time.